Thank you for joining us. I'd like to welcome everyone to the STS 2024 webinar series. Today's webinar is titled The Future of ACHD Training and Certification. Please note this webinar is being recorded and will be available on the STS website and YouTube channel. At this time, I am pleased to announce our moderators for this evening, Drs. Najm and Hancock Friesen. Dr. Najm, let me turn it over to you.
Thank you so much, Amanda. And I would like to welcome everyone to this webinar. This is on behalf of the Adult Congenital Heart Surgery Task Force of the STS. What we thought through our discussions is to give a platform and an opportunity for people to give us their thoughts about how should we go about with the adults with congenital heart disease surgical training and certification. So what we thought is we will have 4 speakers that would trigger some of the discussion points, and then we could have a question and answer towards the end of our webinar. There will be a time. Please prepare your questions. You can have the ability to write your questions in the chat box on the side. Just press on that and put the question and answer, and we will take care of these questions as they go along. So put them on as the speakers speak, and then we will take them towards the end of or after the four talks. And you feel free to add some other questions that we can discuss with the panelists also. I'll hand over to Dr. Camille Hancock Friesen to present the first speaker. Camille.
Thanks, Hani. So we'd like to kick off this evening talking a little bit about some vision for surgery for the adult congenital heart surgery patient and future of the field. And to do so, Dr. Castigliano Bhamidipati is an associate professor of cardiothoracic surgery at the Oregon Health and Science University in Portland, Oregon. There he is the surgical program director of adult congenital heart disease surgery. He's the vice chair of the Society of Thoracic Surgeons workforce on the surgical treatment of adults with congenital heart disease. And as of 2024, he is a member of the ACHA Medical Advisory Board. Cassie, welcome. Thank you.
Thank you so much. Everybody, can you folks see my screen?
Not yet, Cassie.
Okay. Let me.
Yes.
Okay. Okay, good evening, and thanks, Dr. Najm and Dr. Friesen Hancock for that kind invitation. I really appreciate the STS for this opportunity to speak a little bit about the work that we're doing as a group for the care of ACHD patients. I'm going to spend a few minutes in talking about where we could potentially be thinking about the future for ACHD care in the United States. I think it's pretty well accepted that adults with congenital heart disease are becoming more and more prevalent in our practices, and we're beginning to see them more and more often based on how this management of single ventricle complex transposition, multiple sternotomy patients who are able to get great care in the past are beginning to show up for more and more care. Around this, our workforce recently had published our view of what the US population would look like, as you see in the blue line. And as you can see, the ACHD prevalence is expected to increase. Our medical colleagues have started a fellowship in adult congenital heart disease, which typically lasts for 2 years. And we are beginning to notice their clinics get filled with more patients. And we suspect that the surgical aspect of our care is going to continue to blossom. At the moment, we have 54 ACHA centers that are accredited to offer ACHD care in the United States. And at least 20% of these patients will end up needing one operation by adulthood. And if they're over the age of 60, about 43% might need some kind of cardiac surgery. These ACHD patients are complex. And when you're going through your pediatric experience, a lot of these comorbidities are not even appreciated amongst these ACHD patients that we continually see on a daily basis today. Overall, when we look at the congenital training program and the factors that go into it, typically today patients are being cared for by congenital cardiac surgeons who are focusing on adult care, or adult cardiac surgeons who are actually completely committed to ACHD care. These patients are complicated. They might have mild, moderate, or complex congenital lesions, and involve a broad range of pathologies. The current ACHA document calls for at least 2 ACHD surgeons in a program, and the director should have a congenital certification, although we know that there are many congenital programs out there that actually have dedicated ACHD surgeons who are leading those programs. There are a few programs where the surgeon may not specifically have a congenital certification. So how do we get here? If we look at the current pathways that are available, in blue, you see that the integrated residents have to do a 2-year congenital certification program, which will take a total of 8 years to finish. There's a 4+3 program through the general surgery route, again, needing to do 2 years of the congenital certification. That'll take 9 years to finish. And then the 5+2 and the 5+3 and so on. So ultimately, anywhere between 8 years and 10 years, you would end up with a congenital certificate, although this does not include any enrichment time that you might take for research or degrees and so on and so forth. So the current gaps in this particular model that we have is that the limitation to the congenital pathway is through an ACGME certification process, which does not necessarily have a broad range of ACHD exposure with its full complexity, and certainly doesn't expose the candidate to the systems of care that are required to care for these patients. And there's no formal ACHD specific training that is available in the United States today, and that's a lot due to the variation in the practice, patient presentation, case mix, et cetera. And so a lot of the ACHD work at the high end is really reliant on mentorship and exposure to on the job. So again, nearly 300 congenital surgeons that are trained nationally are treating 5% of the lesion burden, and they're limited by the certification process. Most of the surgeons are primarily based at congenital hospitals with a limited resource for taking care of some of these more complex patients. The care model has, seen multiple patients needing advanced care. And as the severity of the lesion increases, they end up with a 3 times likelihood of needing urgent surgical intervention. In fact, substance use disorder, just as one particular entity in ACHD patients, is extremely high across gender, across urban or rural populations with mild or moderate disease, and is insurance independent. We also know that congenital training and case volume has a factor in mortality. Pediatric versus adult surgeon managing ACHD cases has a difference in mortality. And Dr. Camille has shown in the past that 95% of the cases were being done by non-congenitally trained surgeons. Of course, this data has evolved now. We also know that where the hospital is, as we see in the graph on the right, can make a difference on how care is provided. So in less competitive markets, a congenital patient who has a complication has 8 times the odds of having a mortality because of their inability to rescue that patient from a problem. So I think when we think about this, there's sort of 2 broad ways. One is a natural way of letting our programs evolve. And another is a little bit more creative way where we could standardize the minimums for ACHD case requirements, creating some conversation on how we would develop these programs and talk about what the certification really ought to look like. This is just one thought around what a fellowship training program could potentially look like for ACHD interested candidates, where they do a minimum of 50 cases, really focusing on heart failure, managing right-sided disease, looking at MCS devices, getting exposed to transplant, understanding all the nuances of structural management, understanding how aortic disease is managed, and then all the other pieces around the allied health and support services for systems-based care for ACHD patients. Like I mentioned, these patients are complex, and I realize that this time is limited, but hopefully a quick touch on what the optimal pathway might be. How do we prepare for this complex group of patients, and what are the gaps in the training that are available have been, give you some thoughts to think about. Where we are and how we move towards developing patient access for ACHD surgeons is important. And ultimately, I think we would all agree that they probably have equality. I don't know that they have equity, but they do deserve it. Again, thanks for your attention. I appreciate this opportunity to share some thoughts.
Thank you, Dr. Bhamidipati. Again, if you're joining us late, please, if you have questions that you'd like to ask the the panelists at the end of their presentations, we'll have time for some question and answers. We'd like to move on to our second presenter now. Dr. Reilly Hobbs is an assistant professor in surgery at the University of Utah Primary Children's Hospital. He has an active clinical practice, and he's also the surgical director of the Coronary Anomalies Program at the Children's Hospital and the Pediatric Cardiac Surgery Section Lead for Adult Congenital Heart Disease Surgery. He serves as the course director for the annual Intermountain Health University of Utah Adult Congenital Heart Disease Symposium, and he's going to speak to us about one particular clinical challenge that we face in adult congenital surgical management, and that is the management of anomalous aortic origin of coronary arteries. Dr. Hobbs?
Just sharing my screen. Can everybody see my screen?
It's flashing on and off. There we go.
Is it still flashing?
Seems like it's settled down.
Oh, perfect. Well, thank you so much for the invitation to talk about this. Anomalous origin of coronary arteries is something that we all see on a routine basis in congenital heart surgery. But, what's interesting is that, like many pediatric centers, we have affiliations with two different adult hospitals that kind of bring us to different centers, and managing these lesions between a children's hospital and two different adult hospitals can be challenging. So I'm not going to talk in great detail about the management and the diagnosis and kind of when or when not to operate, but I will talk a little bit about how we've developed a program and how we approach these lesions as a group. So as we know, anomalous coronaries are increasingly recognized. We're doing CT scans more and more frequently in these days. It's anywhere from 1 to close to 6% of the population, depending on which papers you read. For the purpose of this talk, and really we're going to focus on anomalous origin of the right coronary artery and the left coronary artery. So if you want literature and a background of kind of managing these patients, when to operate, what the ideal imaging strategy is, and exercise testing, there are some fantastic papers, and I'm not going to go over them. This is one that Carlos Mary is a senior author on, and he's been really instrumental in helping me kind of develop our own coronary anomaly program. So I owe a lot of debt to him, because he came out here and he gave a grand rounds for us, and he's also been a great asset for us, and I've been able to call him quite a bit over the last several months as we've gotten this off the ground. There's, the decision to operate on these lesions is challenging, especially anomalous right coronary arteries, which is what we see primarily. Anomalous lefts, it's fairly straightforward. And some of the problems we have is that most of the anomalous origin of these coronary arteries, the expertise lies in pediatric centers. But we're seeing an increasing number of adult patients who are presenting with these problems. So the expertise that we have is in the medical, the imaging, surgical treatment. So we really have to collaborate with our adult colleagues, so our adult cardiologists, our adult surgeons, so that we can care for these lesions. So our approach is that we developed a formal coronary anomaly program, and we use this program as kind of a consultative service where we actually will review patients. Any patient who's seen within our pediatric center, so within Primary Children's Hospital, is evaluated by our program and all the multidisciplinary providers there. But in addition, what I was finding is I was being called to two of our adult hospitals, and often it's a little bit unsettling to go to a hospital where you're not familiar with the cardiologist, you're not You know, at times you're not as familiar with the patient, you haven't met them before. So we've actually started consulting on all of these patients. So we will review the patient's imaging, we review the history, and it's really helpful for me to have, you know, some really smart cardiologists, imagers, and sometimes even other surgeons comment and kind of help make the decision of when to or when not to operate. So the team members, so there's surgeons, I'm the surgical lead, but we'll also have adult surgeons. So when adult surgeons from other hospitals have patients that they're referred, we invite them to the meeting. Within our meeting, we have some just amazing sports cardiologists. We have some folks with expertise in exercise testing, which I think is really important for these lesions. The meetings are attended by interventional cardiologists. We also have some specialists in cardiac MRI and cardiac CTA. So our approach is that we have monthly meetings, and during those meetings, we will review patients that are being put forth for surgery, or perhaps it's a referring cardiologist from Montana or Alaska or somewhere else that, you know, are planning to send a patient down. We'll talk with, you know, adult cardiologists from time to time too. We'll talk about program development, and really a big component of this is developing protocols. So, you know, how are you going to test patients? Are you going to operate on all anomalous coronary arteries? What are kind of your imaging characteristics? What are your shared decision-making characteristics? And, you know, sometimes that involves a lot of counseling with the families. What's the follow-up? What's the testing to make sure that you're happy with the results? Exercise testing, serial imaging, so that we can follow these patients and make sure that, you know, they're not just cared for well operatively, but they're safe after the surgery. And as I mentioned before, we review all patients that we're going to operate or review here in our congenital heart center. And then we also talk to, you know, we talk to our adult referring cardiologists. We invite all of the referring providers to attend the meeting. And I think that's been really helpful for me, especially as I was early on in this process. Sometimes I'd be called, and if you don't necessarily agree with the decision that someone needs an operation, it's really helpful to be able to say, listen, we reviewed this with the cardiologists and a lot of people with expertise, and we think this is a patient that's better off, you know, managed medically for the time. So the results, you know, I don't have anything published or anything, you know, that I can put on paper so far, but what I can say is that there's been increased patient confidence. It's nice for patients and families to know that a lot of really smart people with expertise are evaluating their case and making decisions whether or not to operate. I think that, you know, our cross-sectional imaging is just fantastic, and, you know, kind of sitting down with the imagers and reviewing imaging before surgery in kind of a programmatic and kind of, you know, calculated way, it's really helped with our surgical planning and, you know, knowing when you need to reimplant or what strategies you need to employ. And we've also seen that as word's gotten out in our heart center and kind of the referring centers, that we've had a pretty significant increase in volume of patients who are being referred to us. Not all of these patients are surgical, and I think that's an important, that's a really important thing to remember with the coronary anomalies. Not everybody needs to have surgery. And increasingly, it's just nice to be able to evaluate, because many of the cardiologists, both adult and sometimes pediatric, are not necessarily comfortable managing these patients, and it's helpful for them to have a resource within the region that they can rely on. Again, the program that we've started, we've been really happy with. I really owe a debt of gratitude to Carlos Mary. He's been a great mentor and helped us get this off the ground. And I reach out to him often, and we've modeled a lot of what we've done after what he did at Texas Children's and also at Dell Children's in Austin. They also have a coronary anomaly course and kind of a symposium down in Texas each year that I attended last year with a couple of the cardiologists that are part of the program, and it's a great experience, and you learned a lot, and it's really helped us come up with a good algorithm for how to treat these patients and collaborate with the adult colleagues. If anybody has any questions, I encourage them to reach out. This is my email. Just feel free to email anytime.
Thanks, Dr. Hobbs. We're going to now move on to our third presenter, who's Dr. David Mockley. Dr. Mockley is an associate professor the Department of Surgery in the section of pediatric cardiac surgery at University of Washington, Seattle Children's Hospital. He's the surgical director of adult congenital heart disease at the University of Washington Medical Center and surgical director of pediatric mechanical circulatory support at Seattle Children's. He's going to be presenting to us a vision for the future of ACHD training and certification with specific emphasis on critical care.
Thank you. Can you all see my slides?
Yes.
Great. Well, I'm going to start the talk by giving my disclosures, and I would say there are none other than the fact that I am a pediatric congenital heart surgeon most of the time that does operate on adults with congenital heart disease, primarily at an adult hospital, which means that about 1 day a week I'm at the adult hospital, and the rest of the time I'm at the children's hospital, which is where I also take call. And the reason I bring this up is because one of the biggest stresses I have is being at the children's hospital, doing something clinical, operating, being in the ICU or whatever, and having issues with my patients in the ICU at the university hospital and not being able to tend to them. And so for that reason, when I talk about ACHD ICU issues, the goal in my mind is to completely avoid them if you can. And I realize that that sounds kind of silly, but there are a lot of things that you can do preemptively to help reduce the number of issues. Things like patient selection, which I'll talk about briefly, careful operative planning, recognition of physiology that's really foreign to an adult ICU team, and communicating that very clearly to them so they know what to expect. And then having lots of help, and I'll touch on this at the end, but the ACHD cardiology group at the university, as well as some of my colleagues, particularly in aortic surgery, have been extremely helpful in making the program work. Just to briefly talk about the UW program, I am the surgical director. I am congenitally trained. I do split the patients with one of our aortic surgeons, particularly because many of the patients have aortic valve and ascending aortic issues. And I frankly think that they're better served in his hands. I do have clinic and an OR day 1 day a week on Wednesdays. And the rest of the time I spend at the Children's Hospital. We have a weekly multidisciplinary adult congenital conference where we discuss patients, much in a similar fashion to what Reilly was talking about, but all aspects of adult congenital heart disease. UW Medical Center is about 1 mile from Seattle Children's Hospital, which isn't too far, but it sometimes can take quite a while to get there depending on traffic. And so it's not super easy to just pop over there if there are issues. And historically, the program did have a surgeon who was only at the university hospital and did all of the adult congenital operations, which is what they're used to. Just briefly touching on what kind of patients we see on a regular basis. I don't know, this is probably similar to most adult congenital programs, but the majority of the operations we do involve the aortic valve, the ascending aorta, or the pulmonary valve and the RVOT. Most of those patients are pretty straightforward in terms of postoperative management. It's when you get into some of these other patients, when in the mitral and left AV valve group, some of those patients will have systemic right ventricles, which can be challenging for the ICU. Some patients will have single ventricles, which is also a bit of a challenge. And then some of the patients with septal defects can also be challenging depending on their pulmonary vascular resistance. In terms of patient selection, as I was mentioning, the vast majority of patients are young. The vast majority do have 2 ventricles. Usually they have reasonable ventricular function. Unfortunately, most of them have had 2 to 5 prior sternotomies and sometimes even more than that. And most have normal pulmonary vascular resistance with some exceptions that we'll discuss in a minute. However, those with poor function or single ventricles, I strongly consider bringing them in before their operation for a pre-surgery tune-up. And What I mean by that is having them admitted to the cardiology service, taken to the cath lab where they have a swan or a PA line of some sort placed, and have them diuresed in the ICU until we are very satisfied that they're at their dry weight, and sometimes start some inotropes just to make sure that they have, they're going into the operation with as good a kidney and hepatic function as is possible. And I've found that that has really decreased some of the postoperative comorbidities in patients that I was particularly worried about. When it comes to careful surgical planning, the sternotomy in these patients can sometimes be the hardest part of the operation. And as you can see in the CT scan that I have up here, the ascending aorta in many of these congenital patients can be quite intimidating when you're planning the operation. And so alternative cannulation strategies have to be explored in all patients. I have a very low threshold for going on bypass and starting to cool before performing the sternotomy, and placing an apical LV vent in patients that have aortic or neo-aortic regurgitation prior to sternotomy as well. You must have adequate imaging before you're going to operate on any of these patients. And the reason I bring any of this up is that avoiding disasters during reentry can really significantly reduce the amount of ICU issues that you have. You're going to sometimes get into the heart or get into the aorta on these patients. And as long as you're prepared for that, they'll usually do just fine. I just want to briefly now touch on some of the parts of ACHD physiology that can be confusing to adult ICU attendings and teams. Patients that come out with abnormal oxygen saturation has been one that I've noticed. It often makes people scratch their heads a little bit. And that can include single ventricle patients or older patients that have atrial level shunts that we may be closed in a fenestrated fashion, so that they may have right to left shunting at the atrial level. These patients will often have oxygen saturations in the 80s, which is fine, but it can lead to prolonged intubation and, concern that the SATs don't come up when the FiO2 is increased. And so this is one area where communication is key. Elevated pulmonary vascular resistance is another area where I've noticed that there has been, some issues in terms of management after operations. And one of the main issues is when to remove the pulmonary artery catheter, because a lot of these patients are not going to have significant reductions in their pulmonary artery pressures afterwards in a short amount of time. And they'll often linger in the ICU doing just fine, wondering why they're still in the ICU. And so that is one area where we've often had discussions about how to manage them. And then patients with systemic right ventricles, I ultimately encourage all the ICU doctors to manage them just like they had a left ventricle. And usually if they can, manage them that way and the ventricular function is fine, this doesn't become an issue. But just having that anatomy sometimes can lead to some concern in the ICU that has to be dealt with. Again, communication, this is key to managing patients from afar. I would say every operation I do, I come and I talk to the attendings, discuss the issues during the operation, what the ventricular function is, what level of inotropic support they should expect, what the normal oxygen saturation should be, and sort of upper and lower limits of that. If there are any residual shunts and how that may affect their physiology. And with single ventricles, I always urge them to extubate quickly, as it does help their pulmonary physiology. And then if I have a PA catheter in place, which I would say is fairly rare, I discuss what kind of PA pressures I would expect and what to be concerned about. I also strongly encourage phone calls rather than guessing, as that certainly helps the patients progress. Lastly, I would say that it's helpful to have lots of good help. Whenever I can't get over to the university hospital and have a patient having an issue, I'm lucky in that I have 8 ACHD cardiology faculty that I can call at any time to give me a hand with management. That is absolutely key in making our program work. And then I'm also blessed to have really good partners. Chris Burke and Scott DeRue are both aortic surgeons here, and we've helped each other in many ways over the past few years. And Jay Powell is also one of our cardiac surgeons that it specializes more in transplant and mechanical circulatory support, and he's been a huge asset to the program as well. And with that, I would like to conclude and thank you all for the opportunity to present.
Thanks very much, Dr. Mockley. We're going to move on to our final presenter for this evening. Dr. Jennifer Nelson is with us tonight. She's the Director of Research and Congenital Heart Surgeon at Nemours Children's Health in Orlando, Florida. She is Professor of Surgery at the University of Central Florida College of Medicine. She holds several society leadership positions and recently served for 6 years as the chair of the STS workforce on the surgical treatment of adults with congenital heart disease, which many of us are now serving on. During that time, she led the development of the STS Adult Congenital Heart Disease Mortality Risk Model and the STS ACHD Data Collection Form. She is current chair of the STS Congenital Access and Publications Committee and Congenital Program Chair for the upcoming STSA annual meeting in 2024. Dr. Nelson, we're delighted to have you here to talk about the STS data as it pertains to the adult surgery in the adult congenital patient population.
Well, thank you very much for the invitation. It's certainly a pleasure to be able to describe some of the background, the current state, and the changes imagined in the future for data collection for ACHD within the context of the STS national databases. So thank you. My goals for this talk are really to describe why this is so important, particularly within the context as we're talking about certification and training in ACHD, options for decreasing the data entry burden that is currently surrounding the ACHD data collection form, and specifically some immediate changes that we can expect in the coming weeks, as well as changes further down the line in the future. My colleagues have given a pretty good background, and so I'll move through this part quickly, but as we know, we are dealing with a growing population of adults with congenital heart disease that have presented us with underlying physiologic and anatomic challenges and an increasing burden of cardiovascular risk factors, which, as we know, are uncommon in the pediatric population. Interestingly, the two groups of adults, those with and without congenital heart disease, seem to have very different cardiovascular health experiences. And as Casti mentioned earlier, prior work has really shown us that adults with CHD, including those with repaired, even lower complexity lesions, have a higher burden of cardiovascular risk factors, adverse cardiovascular events, and hospitalizations compared to adults without congenital heart disease, despite the fact that they tend to be younger. And we know that surgery for adult congenital heart disease is increasing and has continued to increase. This graph on the orange line is showing you the cases entered into the CHSD through the year 2018, and you can look at the right-sided y-axis for that number of case records entered. As far as summary statistics for ACHD records that have been entered into the CHSD since the go-live date of July 1st, 2023 for adults, this is patients that are 18 years of age or older being entered into the congenital heart surgery database. The proportion of adults compared to the total or over the total population is now over 12%, which is up from 10% as far as index cases in recent years. In 2021, we described the STS ACHD population in detail and actually found that the cardiac surgery in these patients was associated with a wide range of unadjusted 30-day mortality. And in some cases and case categories, ACHD patients experienced a higher mortality than might be expected for a particular operation compared to patients without congenital heart disease. So the obvious next question for us, particularly members of the ACHD workforce and many on this panel, was why? Why are cardiovascular outcomes different for the two groups of adults who often have the same types of operations? And so naturally, we looked closely at our STS national databases to help explain why. And we went through a very heavy lift as far as a recent upgrade to the CHSD to help us understand why. As you probably recall, the prior versions of the adult cardiac surgery database and the CHSD data collection form did not really allow for comprehensive capture of relevant details for ACHD patients. And also, of the variables that were being used and still are in the adult cardiac surgery risk models, only 60% were able to be found in similar or identical form in the earlier CHSD versions. So since the go live for the ACHD data collection form, which is embedded in the CHSD, we have entered 3,493 records. I guess that was as of September the 9th, and with 80% of those being index cases. So now, armed with more than a year of experience with this new data collection tool, we felt like it was very important to highlight why the ACHD population is so unique and what changes are coming to make the process less burdensome. As you can imagine, with any first iteration of the data collection form of this complexity, it is time to take a look and see what we can do to make the process more efficient. So first, there are important differences in these populations, as you know. And the reason for potential differences in outcomes between adults with acquired heart disease and adults with congenital heart disease is multifactorial. So we'll take a quick closer look at the differences in these populations. And I felt it would be helpful to try to put this in terms of differences in clinical knowledge, clinical systems, clinical practice, and research as we go through this comparison. So first, clinical knowledge related to ACHD has increased over time, but as we've mentioned, this is a population that's still evolving. There are several knowledge gaps due to the relative newness, if you will, of this emerging and aging population. First, and this is probably going to seem obvious, but the anatomy in acquired heart disease patients is usual and familiar compared to the cardiac anatomy in congenital patients, which we know is highly variable. The spectrum of anatomical anomalies and disease severity results in tremendous heterogeneity. The physiology and natural history of acquired diseases such as coronary artery disease are well studied and well understood, whereas the physiological impact of living for multiple decades with various types of congenital heart disease is not well understood, nor is the interaction between CHD and typical comorbid conditions seen in aging, such as hypertension, diabetes, COPD, and a lot of those other comorbidities that Casti mentioned in his talk. And lastly, the late sequelae of operations such as CABG are well studied. But even in the current era of congenital heart surgery, late sequelae of complex childhood operations, such as those that were really popularized in the 1990s, are still revealing themselves as this population is just now reaching young adulthood. So the take-home point here is really that baseline clinical knowledge differs between adults with and those without congenital heart disease. The overall physiological impact of CHD on an adult patient undergoing cardiac surgery is unknown, but critical to study because that new knowledge will ultimately guide system development, define best practices, and influence guidelines. And so clearly, appropriate data collection is central to this. Briefly, to explore differences in these populations from a clinical system standpoint, we know that referral patterns in medical management preoperatively differ between adult and pediatric cardiologists. Operations for ACHD patients may take place in an adult or pediatric hospital, as we've just heard. The surgeon performing the operation may or may not have had formal training in congenital heart surgery, and the patient's recovery may take place in an adult or pediatric ICU. Overall surgical volume for adult acquired operations is much higher than that for adult congenital operations in general. And lastly, cardiology follow-up is highly variable and less standardized and often less available for adults with congenital heart disease. For example, currently in the US, a patient with acquired heart disease who moves to another city or state may expect reasonable access to cardiology care, as you know. But an adult with congenital heart disease may relocate to an area without adult congenital subspecialty care, or they may be encouraged to switch from a pediatric to an adult cardiologist, and unfortunately, sometimes they're lost to follow-up entirely. So over a decade later, we're still far from understanding the answer to important systems questions like this one, but I think that a webinar like this, bringing this into sharper focus is super helpful and well-timed. part of the reason it's been difficult to determine the best care model for ACHD is that the care environment itself is often dictated into which STS registry these patients were being included. The ACHD data collection form allows for standardized data collection for these patients regardless of the care environment. So taking this a step further, standardization has been shown to be beneficial in many aspects of modern cardiac surgical care. And standardized data collection for ACHD can help us identify which system elements seem to provide the safest and most efficient care for these patients, particularly as we look to certification and training paradigms. So let's just take a quick look at the clinical practice differences for adults with acquired versus adults with congenital heart disease. First, operations for ACHD tend to be heterogeneous, as you heard, and often involve multiple procedure combinations. In acquired disease, operations are often easier to sort into categories such as CABG, valve, aortic, and so forth. This clinical practice is reflected in the structure of the operative section of the adult cardiac surgery data collection form, which is kind of why it was built that way. Given the large volume of cases in those type of categories, adult cardiac surgeons have been able to focus their practice on particular operation types and disease processes, such as aortic surgery or mitral valve disease. Percutaneous options have also expanded rapidly for adults without congenital heart disease, as clinical trials for these devices have tended to exclude congenital patients, although that's slowly changing. Another example as well, commonly utilized in patients with two ventricles and ischemic cardiomyopathy, for example, VAD support may be less effective and after single ventricle palliation, and sometimes less available to adults managed in certain pediatric hospitals. Lastly, as we know, social factors and other barriers to recovery from surgery often differ between these patient groups. Frailty and dementia commonly limit independence, and they may contribute to longer length of stay for non-congenital patients, where genetic syndromes and other extracardiac malformations may limit independence more commonly in the congenital population. So the take-home point here is that registry data are essential to improve clinical practice for patients with ACHD. Data specific to adults with congenital heart disease helps us to better understand clinical outcomes, particularly for uncommon procedures, risk factors for rare outcomes, and how to design clinical trials to drive innovation for the ACHD population. Also, the impact of social determinants of health may differ between groups and clearly has widespread implications. So for our last category, clinical research, this highlights the difficulties really in studying patient cohorts that are heterogeneous or small in number. The ACHD data collection form is important because it will facilitate the evolution of mature risk adjustment strategies and benchmarks specifically for cardiac surgical patients with congenital heart disease. Until now, operative risk may have been under or overestimated. This is important for surgeons and institutions because quality reports for centers with a large ACHD population may suggest that performance is actually worse than expected if risk adjustment is not optimized for ACHD. So clinical research on the topic of ACHD has helped to develop the framework for the development of the ACHD risk model, which was recently published, and that was a very valuable educational process. One of the things that we learned is that stratification by procedure type is not sufficient to guide decision-making nor inform consent for adult congenital patients. A second thing that became apparent was that mature quality metrics and risk models were available for adults having specific operations, but customized risk models and quality metrics for ACHD were still needed. So the good news is that the first iteration of the ACHD risk model has been developed, and an online calculator will be available soon. And central to these efforts clearly is optimal data collection. So to summarize, when comparing populations of adults with and without congenital heart disease, there are many important differences, as we know. The cumulative impact of living decades with CHD is not well understood, but we're now ready for the next iteration of the adult congenital data collection form. We received a lot of helpful feedback, particularly from our data managers that work very hard to put these data elements in. And now we understand the options for making changes. So the exciting bit is, what are these changes? And they come in two categories, and we're pursuing both of these. So first, behavioral changes. So that's essentially offering education to our data managers and surgeon membership to alter the requirements and the recommendations for which cases and which data types are entered into the current form. And those type of changes can be implemented now. Second, changes to the software. Obviously, these require a bigger investment of time and resources, and those are planned for the next upgrade. So the big reveal is for the right now solution, we're currently finalizing a minimal or minimum data set for adult non-index cases. So that means that the fields that data managers will need to enter for adult non-index cases will decrease immediately from around 600 to approximately 20. The data managers are going to still have to identify the index versus non-index procedures, but more info on this is coming soon in the form of webinars and other education for our data managers. As far as the next upgrade, this will address various other pain points and inefficiencies in the data entry process that happens at the institutions with the vendor software. For instance, instead of having to click no repeatedly if a current condition doesn't apply to a patient, they'll be able to move through those fields much more quickly. Also, several lab values have not proved to be important or relevant to collect, and those will be jettisoned essentially. And also, there are specific aortic and valve related fields that will be no longer required. Thank you very much for the invitation again to speak in this forum, and for your attention tonight. I'd be happy to answer any questions. Thank you.
Thank you, Dr. Nelson, and thank you to all of our panelists. If you could all turn on your cameras again, we'll answer any questions that have arisen. I don't see any in the chat. Dr. Najm, do you have any questions?
Yeah, great. These were great talks and good introduction to the topic. I do have a few questions to the speakers. Casti, you're proposing a 12 months training. Do you think 12 months is adequate? Do you think that it should be a 24 months? That's number one question. My second question to you, why I'm saying this, because a lot of those patients are heavily weighed into valvular heart disease that are different from adults with valvular heart disease. And the knowledge of more of the congenital lesions would be probably of added value. The second question that I have for you is, you've indicated some of the tracks that how you could have a surgeon with adult congenital heart surgery certification. However, you'll have to account for the existing surgeons who are doing it and doing it very well without that track, as in there have to be a track for existing surgeons to be kind of grandfathered into that area of subspecialty. What do you think about this model, these two questions?
Thanks, Dr. Najm. You know, the proposed model for the one-year training track isn't necessarily set in stone, obviously. What I wanted to provide the viewership is really an understanding of the broad scope of the knowledge base that's going to be essential to the success of the surgeon. I think that Dr. Mockley, Dr. Hobbs, Dr. Nelson have all very nicely highlighted the very broad care that they have to provide to patients, and how this data is captured, and how we're going to have to care for these patients moving forward. So quite honestly, maybe 12 months is not enough. Maybe 24 months is not enough. Maybe 5 years is not enough. But you can't really have people in a training model forever. As you would agree, at some point, we need to provide a safe bank for folks to develop a base and then continue to evolve their clinical aptitude for the care of these ACHD patients as they move forward. What I want to impress is the importance of being exposed to the transcatheter work, the transplant work, the heart failure work, and the multidisciplinary collaborations that are required to care for these patients in an effective way. Depending on where the program is and how it's set up, every ACHD patient takes, months to bring to the operating room. And there are meetings over meetings and specialists over specialists who provide input in the management of these patients. And it really sucks up a lot of time to carefully navigate these patients to and through the operating room. And I think that requires exposure. And I don't know that 1 year is enough. I think it takes some time. The pathways that I was showing is the current pathways that we have in place today. Certainly, surgeons who are doing the work today would all be sort of grandfathered in, I would imagine, into the process, just like we did around 2008, 2009, 2010, when the initial congenital certification process was being discussed. But we should maybe consider a formal mechanism of recognizing ACHD surgical care as a real independent entity, at least, for making it formalized, as we are going to have folks more accountable through the data collection process, more responsible within their hospitals for the care of these patients, and then nationally be able to collaborate in a meaningful way across centers to have quality conversations and care models and so on and so forth.
I agree, Casti. I want to actually ask the panelists, Camille, David, Reilly, Jennifer, what do you think? Any insights about this particular issue of training and certification?
I guess I'd like to ask one question that's volume related to the panelists, and that is, even programs like here in Children's Nebraska and the UNMC, where we have our adult patient population who have had pediatric surgical care for 30 years, even we have at most 30 or 35 adult congenital cases that come to surgery every year. And obviously the transcatheter therapies have taken some of our surgical volume into the cath lab or into hybrid suites. But how does the volume and what are your volumes, and how do they affect our plans for training? And Jennifer, how do they affect outcomes? Are there volume outcomes relationships that you're seeing in the data that we see in the pediatric population as well that aren't 100% correlates but are related to outcomes?
Thanks for your questions. I think just to start with Dr. Najm's and then to go into the volume aspect, I think as the pediatric training has gone towards 2 years, we could potentially conceive of a program that would be tracked. So if you're interested in pediatric congenital versus adult congenital would be one option, where that second year could be structured with more aortic versus more pediatric. And I think the case requirements would have to be built out over, in a thoughtful way with in the future. But as far as volume, that relationship's always been very unclear. As you know, it's controversial and it depends on how you slice it. A minimum exposure to the most frequent case types, and I would say in looking at the database, it mirrors pretty well what Dr. Mockley was showing from the Seattle Children's experience in the University of Washington, that pie chart, that the breakdown looks a lot like that. So I think that's a good starting point. At least we know what the most common operations are. We know which ones are associated with the higher mortality, and that could give us a guide and a starting point for what the exposure should look like in the relative proportions in any case volume requirements. I'd love to hear what the others think too.
Yeah, I'll go next. I've thought about this a lot, actually. I'm the program director of our congenital fellowship here, and so training is something that's on my mind a lot. And I agree that I think the perfect ACHD surgeon would have a year of congenital training, 6 months of aortic training, 3 months of transplant and mechanical support training, and 3 months of structural heart training. So that's 2 full years. I do think a year of congenital is important for the reasons that Dr. Najm mentioned, that when you're trying to repair a tricuspid valve in an Epstein's patient versus one with a normal tricuspid valve, it's a completely different operation. The same goes with the mitral or left AV valve in a patient with a canal. They're just completely different valves. And so having that base knowledge that you get with the year of seeing all these different anatomical variants is very important. However, the reason I have my aortic colleague do most of the aortic work is because he's better trained. He should do it. He's excellent. He has very good outcomes. And so, you know, that there's a huge aortic component to ACHD these days. And I think that in the past, it was a lot of pulmonary valves, a lot of septal defects, but most of those are done in the cath lab these days. And so a lot of that has gone away, and it's really shifted to the aortic side.
Reilly?
You know, we have an interesting approach here. So we have 4 pediatric heart surgeons, and you know, 2 of us probably do the most adult congenital. Any adult congenital we do at the Children's Hospital, you know, I'll be the surgeon of record and you know, take care of the patient in the ICU. But every adult congenital case that we do at the Intermountain Health or at the University of Utah, we do with another adult surgeon. And that could mean that it's a case that I go and I assist on and I help through it. It could mean that it's a case that I go over, and if it's a Ross, I may do the Ross and they may do a cabbage. But, you know, it really, you know, the more that I do this and go over, the more convinced I am that, you know, I'm never going to be as good as one of my adult colleagues at a maze. And a lot of the patients that we see need a maze. And likewise, they're not as capable as I am if it's, you know, doing a Warden procedure or something that's more along the congenital realm. So, you know, kind of the partnership model that we have, I think is I've really enjoyed it. You know, the challenge is that I think that you have to be committed to it and you have to work with the same people on a routine basis. I think that model doesn't work if the only time you're operating with somebody is on a, you know, 8th-time redo transposition that needs a root replacement. You know, we're pretty programmatic where we will, you know, even if it's, you know, a fairly straightforward, if it's a congenital case, we'll go over and we'll assist or we'll do the case. But then there's an adult surgeon who's very capable, who's the attending of record that takes care of the patient in the ICU. They write the notes, they interact with the family. And it also allows me to have the bandwidth that, you know, we don't have the time to go over and do the volume of adult congenital while still maintaining practice at the pediatric hospital. There's just not the bandwidth. But for me to go over and scrub for 2 hours a couple times a week to do a few cases that's very manageable. And we've had really good outcomes with this. I think that, you know, the adult colleagues enjoy it. I really enjoy operating with them. And I think that, you know, the adult world is so specialized. What we do is so specialized. I just think it's very challenging to be familiar with the congenital lesions in the way that you should be, while also being familiar with all of the nuances about artery constructions, transcatheter therapies. I just don't think that in most practices that's a possibility unless you were perhaps only doing adult congenital. I don't see how you could do it very easily if you were also doing pediatrics and neonates. So that's been our approach, and we've been pretty successful with it.
So we've got only a couple of minutes left, but I wanted to hear from Jennifer also. I think we do agree. I mean, I'm in an integrated system also, and I do the adult congenital and the J side, which is the adult side of the Cleveland Clinic. And at the same time, obviously, I operate across the other building and do the pediatrics. That it's the same building, it's different wings. But I think I do agree with you, David, and Reilly about this. I think interaction with the adult surgeons and some of that. Actually, a lot of the adult cases, aortic adult cases, they do them on their own because obviously we have a huge adult aortic surgeons at the clinic. Jennifer, you practice in a combined integrated system, or basically a children's hospital that does adult congenital cases?
Yes, I work in a freestanding children's hospital that will do select adult cases, but it's a smaller proportion that another hospital like Dr. Hobbs, for example, or yours that has is more integrated within an adult system.
Yeah, and that's why I think it's at least a collaboration with an adult program would also bring you cases, because then you get actually more of the coronary cases that that we get here and Reilly gets, and he actually shared how you get that program up and running because you have this referral channel that comes in from the adult side, the coronary side, so which gives you this added value. I know we're up to the end of the hour here. Any burning points, Camille, David, Casti, Reilly, and Jennifer?
No, I just like to thank everybody for their contribution, and we'll hand back to the STS. I think this was the start or the ongoing discussion that the STS adult congenital surgery for the patients with adult congenital heart disease is hoping to host and overcome over the next weeks and months. So thank you for joining us for the conversation, and we look forward to more.
Thank you.
Thank you.
Thank you so much to our moderators and panelists for your participation and insight. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code on your screen. Registration opens soon for STS 2025. Find more info on the calendar of events at sts.org. We hope to see you there. Thank you and good night.